A 30-year-old man reported tooth loss in the upper front area after a traumatic event. This included the removal of the upper left central and lateral incisors, along with cuts in the upper and lower lips. The teeth that were removed were kept in milk after a short time outside the mouth and were taken to the department an hour later, with a 1-hour delay. After a thorough examination using both clinical and radiographic methods, no movement or fractures were detected. The extracted teeth, specifically numbers 11 and 12, underwent oral endodontic therapy and immediate replantation was planned. Later, the alveolar sockets were rinsed with saline to eliminate clots and any visible debris. Reimplantation into the sockets took place after wrapping a platelet-rich fibrin, PRF, membrane around the root surface. To ensure stability, a semi-rigid wire and composite splinting were employed for a 2-week period, and a course of antibiotics was given. An investigative cone beam computed tomography (CBCT) scan showed cortical bone loss in the buccal area of teeth 21 and 22. Consequently, an interdisciplinary strategy was adopted to regenerate the osseous defect. Follow-ups occurred at 2 weeks, 4 weeks, 3 months, 6 months, and 1 year. The assessment at the 1-year point indicated the absence of clinical symptoms and successful healing, with no indications of radiographic resorption. Medical history. During the medical history assessment, it was determined that the patient did not have any linked systemic conditions. Extraoral examination. In the examination outside the mouth, it was apparent that both the upper and lower lips exhibited swelling and were also cut. Intraoral examination. In the examination inside the mouth, the patient showed the absence of the upper left central, 21, and lateral incisors, 22. Treatment planning. The procedure initiates with a comprehensive examination and diagnosis, where both fields collaborate to assess the degree of harm to the tooth and its pulp. Endodontic therapy objectives. Preserve the tooth by extracting the infected or inflamed pulp. This action alleviates pain, eradicates infection, maintains the natural tooth, reinstates functionality, and averts tooth loss. Results achieved. Safeguarding the tooth and avoiding the necessity for extraction is achievable. A competently executed root canal can offer respite from discomfort, reinstate functionality, and enable the tooth to operate normally for an extended period. Periodontal therapy, splinting. Objectives. Periodontal splints are employed to facilitate a recovery period in locations undergoing tissue repair and to reinstate typical function in regions where the soft tissues alone cannot endure occlusal forces. Results achieved. Facilitating the healing of tissues with decreased pressure on impacted teeth and facilitating proper operation in regions where the tissues alone couldn't endure biting forces. This can result in enhanced stability, ease, and functionality for individuals with compromised teeth and gum tissues. Collaboration. Endodontists and periodontists are dental specialists who collaborate as a multidisciplinary team to provide comprehensive oral health care. Endodontists focus on treating dental pulp and tissues around tooth roots, while periodontists specialize in gum and supporting structure diseases. Their collaboration involves coordinated treatment planning, preventive care, and addressing surgical procedures. This joint approach is crucial for preserving natural teeth, optimizing treatment outcomes, and educating patients about the interconnected nature of endodontic and periodontal health. The multidisciplinary team ensures a holistic approach to patient care, emphasizing functionality, aesthetics, and long-term oral well-being. Collaborative efforts and communication strategies. Following clinical and radiographic examinations, it appeared that there were no fractures or mobility issues. The crown and root surfaces of the avulsed 11 and 12 are intact, and their apices are closed. Using a periodontal splint, an urgent replantation was scheduled after an extraoral endodontic therapy. Procedures and outcomes. Managing avulsed teeth necessitates a collaborative approach between endodontics and periodontics, each discipline offering distinct yet complementary therapeutic strategies. Endodontic management. Immediate replantation, when feasible, prompt reinsertion of the avulsed tooth into its socket is crucial. Gentle cleansing with saline or milk is recommended, avoiding contact with the root surface. Splinting. Following replantation, stabilization with a splint is often necessary to facilitate tissue healing and prevent tooth movement. Root canal treatment, RCT. In many cases, RCT is indicated to remove damaged or infected pulp tissue within the tooth, promoting long-term success. Long-term monitoring, regular follow-up with clinical and radiographic evaluations is essential to detect and address potential complications like root resorption. Periodontic management. Stabilization and splinting, similar to endodontics, splints or wires can be used to stabilize the avulsed tooth and ensure optimal healing. Socket preservation. When immediate replantation is not possible, socket preservation techniques come into play. These involve placing bone graft material in the empty socket to maintain its structure and minimize bone loss, thus paving the way for future implant placement if necessary. Guided tissue regeneration, GTR. For cases with severe damage to the periodontal ligament and surrounding tissues, GTR may be employed. This procedure utilizes barrier membranes and bone grafts to stimulate the regeneration of bone and periodontal tissue, promoting long-term tooth stability and function. Long-term management, regular maintenance and follow-up are crucial for the long-term success of avulsed tooth management. This includes regular periodontal cleanings and monitoring for potential complications.
Teeth preservation and symptom relief. Endodontic intervention resulted in the successful preservation of teeth 11 and 12, effectively addressing the patient's pain and discomfort. Replantation served as the primary method of stabilization. Post-operative course. Following treatment, a 5-day course of oral antibiotics was prescribed. A cone beam computed tomography (CBCT) scan, performed 2 weeks post-operatively, revealed a loss of labial cortex in the region of teeth 11 and 12. Multidisciplinary referral. Due to the observed bone loss, the patient was referred to the Department of Periodontics for comprehensive management of the maxillary anterior region. Reattachment and healing. Splinting was employed to facilitate the reattachment of teeth 11 and 12 to the surrounding bone and periodontal ligaments. The splint was removed after 5 weeks, as positive periodontal outcomes, including healing and stability, were achieved. Restorative intervention. A composite restoration was performed in tooth 11 to address the dentin extending fracture.
Long-term monitoring and surveillance. Prevention of complications. In recognition of the potential for complications, despite successful treatment, a rigorous follow-up regimen was implemented. Radiographs were obtained at 3 weeks, 1 month, 3 months, 6 months, and 1 year post-operatively. Intact periodontal structures. Throughout these review visits, the periodontal ligament space and periapical structures exhibited a healthy and intact appearance. Figure 1. Panel A and B, postoperative clinical and radiographic images showcase the successfully reimplanted teeth 11 and 12. Panel C, this panel illustrates the restorative management of the fracture in tooth 11. Panel D, a 1-year follow-up radiographic image, demonstrates the long-term stability and health of the reimplanted teeth. A. B. Postoperative clinical and radiographic images of reimplanted 11 and 12. C. Restorative management of fracture 11. D. 1-year follow-up radiographic image. Immediate replantation of avulsed permanent teeth is widely recognized as the optimal approach to uphold both functional and aesthetic aspects of a patient's oral health. In the case of teeth 11 and 12, the decision to replant one tooth immediately and the other after a 4-hour delay required careful consideration. Immediate replantation is preferred as it increases the likelihood of successful integration into the socket by preserving viable periodontal ligament (PDL) cells on the root surface. While a 4-hour delay may still offer benefits, the success rate tends to decrease with prolonged time between avulsion and intervention. During any delay, it is crucial to store the avulsed tooth in a suitable medium, such as Hank's Balanced Salt Solution (HBSS) or milk, to maintain the viability of PDL cells. Post-treatment care is of paramount importance regardless of replantation timing. Vigilance for signs of infection, timely administration of antibiotics, and regular follow-up appointments are critical for evaluating healing progress and ensuring the long-term success of the replantation. Aesthetic considerations, including alignment and stability, are vital, often requiring additional procedures like root canal treatment or splinting to optimize both appearance and function. Proper stabilization is a crucial element in managing avulsed teeth, aiming to securely anchor the replanted tooth in its socket and prevent harmful movements that could hinder the healing process. Utilizing splinting techniques, such as bonding the avulsed tooth to neighboring teeth with materials like composite resins or wire, plays a crucial role in providing stability during the initial stages of healing. The timing of splinting is crucial and is typically done immediately after replantation, though it remains a viable option even with delayed intervention. The duration of splinting varies based on the severity of the avulsion, with flexible or rigid splints chosen accordingly. Consistent monitoring, maintaining oral hygiene, and attending follow-up appointments are essential throughout the splinting period. Patients are educated on post-splinting instructions, emphasizing the importance of avoiding activities that could compromise tooth stability and promoting careful practices in terms of diet and oral hygiene. Stabilization emerges as a pivotal step in overall success, providing crucial support during the initial healing phase and effectively addressing potential complications related to tooth movement or displacement, thereby contributing to the long-term success of replantation. Conclusion. In conclusion, the effective management of avulsed teeth hinges on patient awareness and adherence to proper transportation and storage protocols. Replantation stands out as the optimal choice, preserving both bone function and anticipating future prosthetic needs. The success of the treatment is a testament to the impactful role of an interdisciplinary approach, as essential dental professionals collaborated seamlessly to thoroughly examine, diagnose, and devise a comprehensive treatment plan. This collective expertise proved instrumental in the holistic and triumphant management of the case, highlighting the significance of collaborative care in achieving successful outcomes for patients with avulsed teeth.